You're listening to the Animal Heartbeat. My name is Kieran Borche.
Hi, and I'm Jose Nogumatos. This is the world's only podcast dedicated to veterinary cardiology. Welcome, everyone, to the Animal Heartbeat, your veterinary cardiology podcast. We have again another very special guest with us today, Professor Chris Orton. Professor Orton is a diplomate of the American College of Veterinary Surgeons and also a diplomate of the American College of Veterinary Internal Medicine Cardiology. Professor Orton started in 1991 a pioneer open heart surgery program at Colorado State University, and his area of research covers a large spectrum from bench research to clinical research. And we are truly honored to have with us today Professor Orton. Chris, thanks very much for accepting our invitation. It's great to have you here.
Thank you so much for having me. It's an honor for me to be here. Thank you for that introduction.
Your research covers a large spectrum in degenerative mitral valve disease, from bench research to clinical research. So we thought to discuss with you your main research findings and also your opinion. But if we start from the beginning, when and why did you become interested in degenerative mitral valve disease?
Well, I think most veterinary cardiologists and cardiac surgeons would be interested in degenerative mitral valve disease. It is the number one cardiac disease in dogs. And my original sort of interest arose from my background in surgery, and we began to explore possible surgical solutions. This was back in the late 1990s. And then my background from my PhD looking at the cellular biology of pulmonary hypertension sort of led us into exploring, could we understand better what might be triggering mitral valve disease at a cellular level? So it's kind of it's been almost a career-long interest in mitral valve disease, and I think it's an important disease that impacts a lot of families and a lot of dogs.
I think there's no doubt it has a huge impact, as you say, on humans as well as dogs. So when you're evaluating something that's inside the heart, that's subject to force and tension, 80, 120, 180 times a minute, how do you study that in a realistic way?
Well, that's a very good question. So if I were to say that the heart valve is the most loaded connective tissue in the body, people might question that. They might think of joints, they might think of tendons. As you say, when you consider the number of cycles a heart valve is subjected to, the need for constant regeneration of the matrix tissues is probably higher than any other tissue in the body. And when you get dysregulation of that maintenance of tissue, that degradation and synthesis process that has to continually go on, then that can lead to a degenerative disease like mitral valve disease, especially when you consider humans over the lifetime of a human. So I think that loading and how heart valves are loaded may be playing a very important role in the underlying pathology of mitral valve disease.
Expand on your work on the loading conditions of valves in vitro, because it's fascinating stuff, I think.
Well, the story begins with some work that came out of Harvard in human degenerative valves. And they discovered that the cells that are responsible for maintaining a heart valve are called the valve interstitial cells. These are basically fibroblasts, that they underwent a transformation from what was termed a quiescent, well-functioning fibroblast into a myofibroblast. Now, there were certain cellular markers for myofibroblasts, including smooth muscle actin. They didn't go all the way to smooth muscle cells. And so this group hypothesized that this transformation of the cells was part of the process, or at the core of the process, of degenerative mitral valve disease. So we became interested in this study, and our first sort of look into cellular mechanisms was to determine if this was happening in dogs. So, and in fact, it was. And we showed that, and other groups showed that canine mitral valves, degenerative mitral valves, were undergoing this cellular transformation. So we started to ask questions around, well, what might be triggering this transformation? If this was really responsible for degenerative disease, could we understand what the triggers were? Now, it's very interesting that you ask about loading conditions. That gets towards the end of the story a little bit, but if we look at the structure of heart valves, it's really conserved among vertebrates. Birds, for example, have the same structural components as a mammalian heart valve. And so one interesting observation was this transformation tended to occur first along what's called the atrialis layer. And that's the layer that's subjected to shear force. So the atrialis layer has lots of elastin, radially aligned to help with shear stress. And so it's been suspected and probably widely accepted at this point that turbulent flow across the face of a valve can induce myxomatous change. And that seemed to be consistent with where the cells were changing first. Now, the other force that you might think about as far as a trigger would be, are these valves being subjected to excessive tension? What could do that? Well, maybe hypertension can do that, although the evidence in dogs is not super strong that hypertension is a trigger for mitral valve disease, but perhaps we don't know. So we became interested in, it's possible to do lab experiments and benchtop experiments to measure shear. That's not something we did, but we collaborated with a researcher who did joint research, and he had a machine for subjecting cyclic tension or strain to tissues. So we mounted canine and sheep heart valves in this benchtop machine and watched what happened over a period of about a week. And what we did, in fact, find was the more we loaded these valves, the more strain we subjected, tensile strain, the more that this transformation occurred. So in dogs, we might ask the question, how might tension be involved in the pathogenesis? One would be hypertension. But then if we think about, that dogs that get degenerative mitral valve disease tend to have a small stature, they're small breed dogs. Is there something about small breed dogs that led over a period of time to, for lack of a better term, connective tissue disorders that might inherently make their valves weak and more susceptible to the normal loading forces of valves?
Besides tension, I believe shear forces will be other potential force that the valve will be exposed to. And we have the classic dogma that MR begets MR. Is that real? Can shear forces of normal turbulent flow contribute either to initiating the process or contributing to the progression of the disease?
Well, there is interesting experimental data to support that, and of course, clinical observation supports that for many years. But there was a classic experiment that was done in sheep where they punched a hole in one of the mitral valve leaflets, which created a turbulent flow directed towards the other leaflet. And sure enough, the other leaflet developed myxomatous change. So I think there is evidence, probably strong evidence, that shear plays a role. And it's interesting that this transformation of cells occurs on the surface of the valve where shear is greatest. So there's a lot of reasons why mitral regurgitation begets worsening mitral regurgitation. One of the reasons that we see in the TEER patients is the progressive remodeling and the secondary functional mitral regurgitation that contributes to the MR is a huge component in humans and in dogs.
And what other factors do we know from your work and from the work of others that are important in those changes? Obviously, we talked about forces, but we know there are paracrine influences, endocrine influences on connective tissue.
Yeah, that's a great question, and one that we became very, very fascinated with. It's been known for a long time, or suspected, and basically proven that serotonin can create changes in the heart valves, including the mitral valve, that mimic very closely degenerative valve disease, especially myxomatous change. So when we go back and we look at the story of fen-phen, which was a dietary drug, a serotonergic drug, actually two drugs that promoted serotonin, that created mitral valve disease in humans. So there was that piece of the puzzle. We know that carcinoid, which is a tumor of the serotonergic cells, can produce very, very high circulating levels of serotonin. And that causes changes in the right heart valves. Now, the lung is very, very good at clearing serotonin as well as the platelets. And so the left heart valves don't tend to be affected in that condition. But it also supports that serotonin can induce these changes. And then there were other studies, like if you take rats and inject them with serotonin, they will have these changes. So there was an interesting finding. What sparked our interest was actually a study by Marco Yama, a transcriptomics study. And he showed, one of the things that he showed was that was upregulated was one of the serotonin receptors. He showed it at the RNA level. We became interested in the question of, okay, can we show this at the protein level? Is this receptor, the specific serotonin receptor called the 2B receptor, upregulated? And sure enough, it was. Now, a graduate student who became a postdoc in my lab from Thailand named Sirilak Dasadian gets credit for the thought that, hey, what if heart valves are able to make serotonin locally? And so there's a key enzyme, TPH1, that is responsible for serotonin production across the body. And she found that, sure enough, this enzyme was present in mitral valves of dogs, and that if you looked at degenerative valves, the more degenerative the valve was, the higher that was. So that led to a hypothesis that maybe we know that serotonin can induce these changes. Maybe mitral valves, maybe a trigger for the degenerative process might be that the upregulation of local production of serotonin. So we reported that in a human journal. We actually showed that in human degenerative valves were also capable of producing serotonin. We put the valves in culture and we demonstrated that serotonin was being synthesized into the culture media. So that actually led to the experiments with placing the valves under tension, cyclic tension, and we showed in dogs static tension or cyclic tension, in fact, induced serotonin production in the valves, induced many of the markers that are associated with degeneration, collagenases, elastases, proteoglycan, which is responsible for the myxomatous change. And so, interestingly, this one receptor, of which there's many, I think there's 13 serotonin receptors in 7 different families. It turns out that this 2B receptor that was upregulated, if you block that, then you could block these changes in the mitral valve. So all of this together led to a white paper that Jens and Mark and I wrote to different drug companies, suggesting that, hey, we have a target for this 2B receptor that may be involved in triggering myxomatous mitral valve disease. And would there be interest? And we had one drug company that had a 2B receptor blocker, and we explored that briefly, but it didn't lead to a clinical trial. I think the evidence is still there. One of the maybe criticisms that you might say of that approach would be, well, do you really want to give a drug to, let's say, Cavaliers for their whole life? Perhaps that's a good question, but maybe if we put that to Cavalier owners based on current thinking, they might be quite interested in that.
I think there are plenty of people who give supplements for joints or any, something like that, which is very much that preventative medicine approach. So I feel like that shouldn't exclude it from the realm of possibility.
I very much agree with that. And then if you think about rapamycin and what we're maybe heading towards for lifetime drugs for longevity.
Sure.
So the other thing about it is, serotonin plays an important role in many tissues, including the brain. So you would probably want a receptor inhibitor that didn't cross the blood-brain barrier and was fairly specific for the valves. And that does seem to be possible with this one receptor inhibitor. So I think that could be explored further.
That's very, very cool indeed. With that serotonin hypothesis that your group suggested, I remember that in one of your papers you described, so we commonly, when we see electron microscopy images of the mitral valve, we see that sometimes platelets are attached to the mitral valve leaflets because they have lost the vascular endothelial cells. Because Cavaliers have big platelets and so on. Is there any potential role for platelets on mitral valve disease?
I think that's a very excellent question. So if we believe that serotonin can be at least a trigger for degenerative valve disease, maybe not completely responsible, but can be a trigger, how can serotonin get to the valve? It can be circulating in the plasma, but platelets are very, very good at absorbing virtually all of the serotonin in the blood, and the lungs and the liver eliminate serotonin. So circulating serotonin is probably not a good candidate, but serotonin in the blood is located in the platelets. And if platelets were to attach to these valves, then that could also be a source of serotonin. I think there is evidence that platelets can be there, but if you look at these valves, I would say the evidence that that platelets are adhering to these valves and triggering disease is not strong. The nice thing about the local hypothesis is, you don't need an external source. If something is triggering the local production of serotonin, we know that can induce these changes. So all three of those hypotheses are possible and have been put forward. But maybe we could also say that regardless of which of those are playing a role, if we believe that serotonin is a key trigger, then we should at least explore a clinical trial with a serotonin receptor inhibitor.
So would that be something, as you say, where you look at dogs and you say there's stage A, if we believe stage A is a real thing. So they're a cavalier, they're 4 years old, they're male, maybe. Is it something we'd start then? Or would we be looking at starting it in stage B1 when we've got an audible murmur, but no significant remodeling? Or is that too late if the valve's already subject to changes which cause the regurgitation, the abnormal loading conditions, and therefore we're already in the early stages of that cycle of MR begats MR?
I think the answer is we don't know, but we have, had preliminary discussions about, okay, if we were to design a clinical trial, one of the challenges would be, when do we start it? And the other challenge would be how long this clinical trial might have to be in order to demonstrate an effectiveness. So
big consideration, isn't it, for these trials?
Maybe not unlike the rapamycin story. It's going to take a while before we understand whether that's an effective strategy or not. But that doesn't mean that we shouldn't think about it. I think it's for other people at this stage, people who are clinical trial experts, to think about how that trial might be run.
If we move now, Chris, to your work on mitral valve repair, and your team has pioneered in the last 4 or 5 years, I believe, trans-catheter edge-to-edge mitral valve repair. But if we start from the beginning, what are the indications in humans for TEER? When would TEER be done in humans versus mitral valve repair?
I think this is a very important question, and it's sort of at the core of the current discussion for TEER in dogs. So if we look at the criteria for an intervention for mitral regurgitation in humans, both the North American guidelines and the European guidelines, the indication is severe mitral regurgitation. Now, severe mitral regurgitation requires an integrated approach based on ASE and other guidelines that considers structural changes, but also qualitative, semi-quantitative, and quantitative changes, and to determine which patients have severe MR. So that is the indication in humans. It's interesting that the human guidelines are indifferent to whether the patient is on diuretics or not. Now, the human guidelines make a distinction between patients that have severe MR and are symptomatic versus severe MR and asymptomatic. But in humans, symptomatic means exercise intolerance or a degree of orthopnea. Symptoms that are probably difficult to identify in dogs for a lot of reasons. Also, it's recognized that human patients will reduce their activity to become less symptomatic. So both for surgical repair and for TEER in humans, it's considered an indication if the patient meets criteria for severe mitral regurgitation.
And how does that translate to dogs? Because as you've identified, we have very different situation in terms of clinical signs versus symptoms that a person's experiencing. And we see so many dogs with stage B1 mitral valve disease that never progress to dying of the disease. Whether or not they need pimobendan's a little different, but looking at the data from Michele Borcarelli's studies and the Look Mitral registry, it feels like about 70% of dogs with early stage mitral valve disease don't die from the disease. So how can we categorize severe MR in dogs based on what we know at the moment?
What I can speak to is the approach that we've taken. So we have, based on the human guidelines, we have considered the indication, the first indication for tear repair, and probably surgical repair as well, but specifically for tear, if they meet adapted criteria for severe mitral regurgitation, then they are a candidate for this procedure, in our opinion. Now, we can talk numbers because this includes some dogs in B2, but B2, stage B2 is not an indication for tear. Because if you actually start to look at MR severity in dogs that meet criteria for stage B2, some of those dogs will only have moderate, even 2+, not even moderate to severe MR when you look more closely. On the other hand, if a dog is in stage B2, has not yet needed diuretics, Cavaliers are the poster child for this. They have very, very advanced disease often before they go into heart failure or have their first episode. If we look at those late stage B2, what some people call B2 plus, in our view, those patients do not have the good prognosis of the B2 category overall. And so I can share some numbers on severity criteria for dogs who have undergone this procedure at our institution.
That would be great. Especially, it would be great also to understand at the moment, what would you consider to be the ideal valve morphology, the ideal leaflet anatomy when you assess these dogs for a TEER procedure? What would be like the perfect case for TEER versus the more complex and less desirable case for TEER?
So there's two considerations when we're thinking about TEER or edge-to-edge repair. First consideration, does this dog meet integrative criteria for severe MR? And I think that's a super important question with regard, especially to B2 dogs, because people have raised questions about whether it's premature to do this on B2 dogs. The second consideration is what has been termed anatomic complexity. Now, if we go back to the early experience in human patients with edge-to-edge repair, they established an inclusion anatomic criteria that the leak needed to be in the central segments, the so-called A2 and P2 segment. And then over time, in the first feasibility study in 2005, they established some exclusion criteria. Some of those were related to functional MR. What has evolved since in the last 20 years in edge-to-edge repair is an understanding of which patients have anatomy that is appropriate for an edge-to-edge repair versus patients who are unsuitable for an edge-to-edge repair. And in fact, as it's evolved, and this came out of the European group, this was not a straight yes and no, but rather needed to be graded. So in humans, and what we are currently doing is we have a graded scale of what we call complexity. And that ranges from non-complex, the ideal case, if you will, would be prolapse of the anterior leaflet with a very eccentric jet. Coaptation is preserved. By that, I mean that the annulus is not so dilated that the leaflets are pulling apart. That would be the ideal case, what we might call a green. And then we work up to complex, very complex. Very complex is when both leaflets have abnormal motion. Flail, degrees of flail starts to be very complex to unsuitable. So we have submitted a publication based on our current thinking. So we don't have consensus guidelines on this yet, but the 4 centers in the United States that are doing TEER, we got together and we decided as best as we could, based on our collective experience, how we should grade these patients. So what we say to families who are considering TEER, we usually give them a rating of complexity. And we say this complexity rating is going to affect 2 things. It's going to affect how well we can reduce the mitral regurgitation, and it's going to some degree predict the risk that we take. The more complex, the more motion there is, the more difficult it is going to be to capture the leaflets and have a stable clamp. So anatomic complexity is a big component, and also making sure that these dogs have essentially a poor prognosis based on severity are the 2 considerations.
Starting a new procedure like this in dogs is a huge learning curve. And I can only imagine the number of different opinions from the team early on and the number of different conversations that must have been had around every case to come to these, local guidelines, let's call them. Tell us a little bit about that learning curve and your experiences. I guess my ultimate question is, as you've learned more about this procedure and you felt more comfortable with it over time, have you become braver or have you become more conservative with your patient choices?
These are great questions. So the journey. The journey began with a trip to China to look at the device in 2020, January 2020, and then we had a little problem with a pandemic shortly thereafter.
But a little hump in the road.
Yeah, a little bump in the road. That delayed things for a year. So we did our first case in January 2021. That was a beautiful dog in stage D, a bear. And for some unexplained reason, we were able to capture the leaflets and put on a clamp, and bear lived for quite a while, almost a year.
I think there is the phenomenon of beginner's luck.
We had beginner's luck. So we did the procedure. I think we did 12 procedures in the first year. And we started to become more confident. But you and I have done these cases together, and you know what it feels like.
I've never had a feeling like it. I could feel my adrenal glands during the procedure.
Well, I can tell you that 119 cases later, which is our current number, it still gives me apprehension.
Right.
I have a case this morning. I have one tomorrow. It's not routine. And I think one of the challenges is that it will never be routine. Has there been a learning curve? Yes, there has been a learning curve for sure on many regards. understanding complexity and who we should do this procedure and who we shouldn't do this procedure, learning how to do this procedure well. And that continues to evolve, honestly. So it's interesting. They looked at this question in humans in a very large registry of 12,000 patients in 275 centers. They looked at the learning curve, and the inflection point for complications and all of the different measures that you might consider for TEER occurred after 50 patients and continued to improve up to 200 patients. So, yes, you have several cases that go really well and confidence becomes higher. And then you have a complication and you really feel very bad about that and you get more conservative. So I would say right now we're in a phase where we realize that not all dogs with severe mitral regurgitation are candidates for this procedure based on complexity. And we have a lot of conversations with owners about alternatives, including surgical repair. And also based on the age of the dog, et cetera, whether or not it's a good idea to take the risk of doing this procedure.
Can you share with us your initial short-term and long-term outcome on those cases you have seen? I think what I guess a lot of people is interested in is to understand how much reverse remodeling happens after TEER. Because if we compare with surgical mitral valve repair, where there is marked reverse remodeling and dogs are weaned off pretty much every medication, it's a very, of course, tough competitor. So could you share with us how much reverse remodeling there is, what the outcome is, and what is the ultimate goal with TEER? Could it be just a bridge, just to delay the disease until potentially surgery is required, or you feel like that maybe there are some dogs that will only need a TEER and that would be enough to stabilize the disease for long enough time?
Yeah, those are great questions and super important questions. And I can tell you that we are preparing what we'll call the intermediate term results right now for submission for publication. That's 2-year survival analysis and 1-year analysis of data. So we have some answers to those questions. Let's start with how severe they are to begin with. If we look at LAAO, for the B2 dogs, that's just under 2.2 short axis. And for the C dogs, that's 2.4. So most people would believe that that's pretty severe. If we look at normalized ventricular diameters, the B2 dogs have been 2.0 essentially, and the C dogs have been 2.1. Regurgitant fraction, the average for the B2 dogs is 57 and is 63 for the C dogs. So what this is going to come down to ultimately is how much remodeling they have depends on how well we reduce the mitral regurgitation. If we look at the average numbers, let's say LAAO, for all the dogs, and this is the 111 dogs, for all the dogs, the LAAO before was 2.3, immediately post is 2.0. 1 year later, it's 1.9. So that's modest remodeling, I think it's fair to say, but the range is quite wide. We have dogs who have remodeled back to B1 status, and we have other dogs who've had limited remodeling. What is that tied to? It's tied to how well we reduce the MR, which actually everything is tied to how well we reduce the MR. And if there's area for improvement, that's where we need to see it.
I almost feel like the early remodeling, certainly, when we compare open heart surgery on cardiopulmonary bypass with a trans-catheter edge-to-edge repair, with the open heart surgery, we do see very rapid shrinking of the heart, but we're performing an annuloplasty in those cases. So we're physically making it smaller, which is something that we just can't do with the minimally invasive approach at the moment. So I almost feel like it's not a fair comparison, really. And what we should be looking at is the longer term outcome.
Okay, so there's a lot there. So first of all, I did a Cavalier last week, stage C, regurgitant fraction in the high 60s. That dog went home with almost no mitral regurg, just a trace, unmeasurable. That was 2 clamps. That's without an annuloplasty, and this dog had a severely dilated heart. So if we can reduce the mitral regurgitation that dramatically, then the annulus will shrink on its own. Now, surgical repair versus TEER. I mean, that's a super important question, and I consider those 2 procedures to be highly complementary. First of all, we don't have enough centers doing either procedure to meet the current demand. So, we have to try to do something. So each of those approaches has its pros and cons. We know this from the human experience, and it likely translates very well to our experience in dogs. Surgery can handle anatomic complexity. They are not limited by the anatomy. It does have the advantage of annuloplasty. That is certainly helpful. Surgery is much more invasive than this procedure. Surgery probably more consistently reduces the mitral regurgitation down to mild or less. TEER, on the other hand, the principal advantage is that it's much less invasive. And we also have to understand that we're in the early phase of the TEER procedure. If we look at the journey in humans, if we go back to 2005, the first MitraClip study, the Everest trial, the feasibility trial, they only achieved mild mitral regurgitation or less in about 60% of the patients. A more recent study, the G4 registry, which is many, many patients, they now achieve mild or less in something close to 95% of the patients.
That's amazing, isn't it? If we could achieve something like that.
It is. Now, part of that is case selection. Part of the human story is they don't have good surgical options for functional mitral regurgitation, and that is one of the better indications for TEER. But I often have conversations with owners about TEER versus surgery, and I consider these 2 procedures to be complementary, not in competition with each other. We have sent patients that have come to us for TEER to Florida for surgery because we thought that they weren't appropriate for the TEER procedure. Owners do tell me, I mean, the advantage that we have to say about TEER is its level of invasiveness. These dogs walk outside the next morning, they go home the day after the procedure, at most 2 days after the procedure. The recovery is very much like an interventional procedure. And many owners will say they would prefer that. Now, there was an interesting study, and we should talk about survival because we do have 2-year survival data, but there was an interesting finding in the first pivotal trial of the MitraClip, which compared TEER to surgery. Surgery was better at reducing the MR down to mild or less than TEER, but had a higher complication rate. The interesting thing was when they looked at survival 5 years later, there was no difference between the surgical group and the TEER group, even though MR was not reduced to the same degree. That was in the Everest 2 trial. And that has subsequently been confirmed by meta-analysis in humans. Now, will that be the same in dogs? Surgical repair is wonderful. The challenge is it's not as available as it should be. Surgery is highly developed in humans, of course, and it's less developed for us. So I think we need both of these procedures, and owners need to have the choice of a less invasive procedure, even if it's not as likely to reduce the leak or get them off of their diuretics. I do have some survival statistics if you want to discuss these.
It'd be amazing if you could share some numbers. That'd be fantastic. I'm sure people would be very keen to hear.
We have survival data out to 2 years now in 111 patients. So if we focus on cardiac-related mortality over a 2-year period, the data is interesting. So there's an inflection point in the survival curve at about 2 months. Something around 87% of dogs are alive at 2 months after the procedure. Before that includes all the patients with a complication or a leaflet detachment. We've had 6 dogs have essentially fatal leaflet detachment. That's our number one complication and fear at this point. Yeah, the time frame for detachment is in the first few days, so-called subacute. So we actually had one detach in the operating room. We put in a second clamp, and that dog's still alive almost a year later. We had another one detached that we were able to go in and put in a second clamp. That dog lived almost 2 years and died of cancer. But generally, in 6 dogs that detached, that resulted in essentially fatal MR that they couldn't survive. So that, and then early on we had dogs where we went in and tried to capture the leaflets, we couldn't. If the dogs make it to 2 months, then the curve flattens out. So for cardiac-related mortality at 1 year, 80% of the dogs are still alive. And at 2 years, 78% of the dogs are still alive. Now, if you consider the group that we're operating on, based on the numbers that I gave you regarding severity, these dogs, the average severity of their regurgitant fraction is 63%. So these are very severe dogs, and that's reasonable survival. We did, because the question of B2 and C comes up, we looked at cardiac-related mortality in the C dogs versus the B2 dogs, and there was no difference. Their survival curves look virtually identical. Now, at some point, when we have more data, we'll need to drill down into this a little bit more and try to understand what predicts a good outcome and what doesn't. But we did look at one thing that I found very staggering, and it goes back to the comments about how well we reduce the MR. So when we looked at dogs that had mild MR, defined as a regurgitant fraction of less than 30%, that's the definition in people. When we looked at the dogs that had a regurgitant fraction of 30% or less immediately after the procedure, versus dogs that had a regurgitant fraction greater than 30%, the difference in survival was highly significant. The hazard ratio was over 4. And even more striking was that the dogs with mild MR, regurgitant fraction less than 30%, had a 100% freedom from cardiac mortality at 2 years across the board. None of those dogs
Great number, isn't it?
died of heart disease. So when we look at all of that ourselves, we ask ourselves, how can we improve getting the regurgitant fraction down to mild or less more consistently? I think there's two aspects of that: the surgical experience or the procedural experience piece, but also understanding which dogs should have this procedure, are appropriate for edge-to-edge repair, and which dogs are not. A disadvantage of TEER compared to surgery is that it cannot handle all of the anatomies that a surgical repair can. But if we make good decisions around that, and if our evolution of understanding of what constitutes an appropriate case continues, and eventually we have consensus guidelines around that, then we might expect the results to improve. Over 20 years of edge-to-edge repair in humans have suggested that the improvement in their understanding of how to do the procedure and based on experience and evolution of devices, it's been a remarkable improvement to the point where now they will consider TEER in patients with moderate or low risk.
Regarding device selection, if you could also share with us your thought process when you're deciding which device to use. Is it a limiting factor only having 3 devices? Do you face situations where you'd need a smaller or a bigger device, or these 3 devices pretty much cover the large majority of cases you see? And also, what is a bit your thought process in terms of how you decide which device to use?
So we now have 5 sizes, ranging from a width of 14 millimeters now up to 22 millimeters. So the 2 bigger sizes have a bigger delivery catheter because they're basically were designed for humans, but they can work quite well in dogs. So when we had 3 canine sizes, the 14, the 16, and the 18, there were quite a number of dogs who we didn't have a big enough clamp for, and unfortunately, a lot of those were cavaliers. Even B2 cavaliers can dilate their heart to such a degree that they weren't candidates. I think now that we have the 2 larger devices, this cavalier, we put in the 20 millimeter device last week. And so that has certainly helped on the upper end. On the lower end, the smallest dog that we have done is 2.7 kilos, which we just got a 2-year photographs and videos from that dog. He's doing really well. But for example, we've heard data from Korea where there's a lot of Chihuahuas and a lot of dogs who are under 2 kilograms that need this procedure. And in fact, probably the smallest device is too big for them. So hopefully, as this procedure is developed, the people who make the devices will continue to expand the clamp sizes so that we can do smaller and smaller dogs and the full range of dogs. We currently cannot help larger breed dogs, perhaps large breed dogs that might have functional mitral regurgitation associated with atrial fibrillation or other causes of functional. We don't have a device for them yet, so maybe we will if we can continue to develop this technique and have what I would say are acceptable results up to this point. I don't think we've reached the level that we need to eventually reach, but I think the results are good enough to suggest that we should keep going.
I think what's interesting for me is that actually the rise of trans-catheter edge-to-edge repair using a clamp device has piqued everyone's interest again in mitral valve replacement using minimally invasive devices. Now, obviously, many of our listeners will know that you've been involved in looking at mitral replacement options in the past at a research level. What are your thoughts on the current opportunities for mitral valve replacement, whether that's open heart surgery or minimally invasively?
Yeah, I think that is an exciting area. So again, if we go back a little bit to the evolution in humans, there is a trans-catheter replacement device called the Tendyne device, which is now approved in Europe and is undergoing clinical trial. Interestingly enough, it's undergoing clinical trial compared to the MitraClip because both of those technologies are owned by Abbott. But the evolution of this device, the replacement versus the edge-to-edge repair device, it's for patients who are at prohibitive risk or not good candidates for surgery. The evolution, to a large degree, has been the limitations of TEER when it comes to anatomic complexity. So we recently looked at a series of talks out of Europe in humans, the title of which was, "Why do we need a replacement device?" And the answer is because some patients are not appropriate for surgery and they're not appropriate for TEER. I think we may be in the same situation in dogs. Now, I probably currently, for the size of dogs that would need a surgical valve replacement, there isn't a commercially available prosthesis. But the question is, can we have a third option, actually a fourth option if we consider LAD, but can we have a third option of transcatheter valve replacement? So there are, interestingly, 3 devices that we know of that are under development for transcatheter valve replacement in dogs. One of them comes from Hongyu. We've looked at this device. I think it has some interesting properties and maybe some challenges. We have seen evidence of another device in Germany, which is fully percutaneous, which would be very interesting. And then we are also now looking at MitraSeal again, which of course is the same design as the Tendyne device in humans and shares the same IP. So I think this is an area that we could see some movement in. Right now, I would say that would be for a dog who has no other options, is not a TEER candidate, for whatever reason, cannot be a candidate for surgical repair. And then as a backup, what if TEER goes wrong? What if we have that dog that has a detachment 3 days after the procedure? We know that we're never going to get them to surgery, and it's probably not a repairable valve at that point. Can we have a rescue option? So I remain hopeful that will also become an option. The first challenge is appropriately sizing the device so that you don't inhibit outflow and you don't create mitral stenosis. The second challenge is that first 3 or 4 months where you have to control for thrombus with anticoagulation. And then we'll need to learn about long-term durability.
My understanding from your initial work with valve replacement was exactly that, a high risk of thrombosis. Do you think that these new devices will be less prothrombotic? And if you would choose antithrombotic treatment, what do you think that antithrombotic treatment might look like for these new valves?
It's a very good question. So way back in the 90s, we implanted some mechanical heart valves. Now, mechanical heart valves have infinite durability, but their flaw is that they require lifetime anticoagulation and a small amount of thrombus can freeze the valve and create a catastrophic situation. So we put in some mechanical valves in dogs. We had one dog live for 5 years, but most of the dogs succumbed in a fairly short period of time. And in those days, we were using warfarin, which is the standard in people. So people have looked at that article and they have said, well, valve replacement doesn't work. But that really relates to mechanical valves. So bioprosthetic valves, on the other hand, are a different story. They don't fail catastrophically, and they do not require lifetime anticoagulation. They require anticoagulation for 3 to 4 months. Can we control thrombus on a bioprosthesis? Well, we put in a surgical bioprosthesis in a large dog in November, and that dog is doing very well. They are at the last stages of discontinuing the antithrombotic therapy. So what should that antithrombotic therapy be? Based on newer drugs, the factor Xa inhibitors, rivaroxaban, apixaban, combined with an antiplatelet drug like clopidogrel is the best guess at this point. We did a phase 1 study in beagle dogs of that drug combination to try to understand what the doses would be. One of the things we found that apixaban requires almost a 10-fold increase in dose compared to humans based on a per kilo basis. Now that's a really expensive alternative, but what we have shown with surgical valve replacement, Brian Skansen has done a TAVR procedure, a trans-catheter aortic valve. We use that protocol. We've done that on surgical valves now with success. So I think a combination of a factor Xa inhibitor, rivaroxaban, apixaban, or the fractionated heparins, enoxaparin, combined with an antiplatelet strategy could work. My previous experience with surgical valve replacement in the tricuspids tells me that if we can control the thrombus for the first 3 or 4 months, then we can come off of the anticoagulant drugs, maintain either Plavix or aspirin for the rest of the dog's life, and that the valve can function well. We have a bioprosthesis in a dog. It must be 5 or 6 years out now in the tricuspid position, and that dog is on clopidogrel. So that's just anecdotal evidence that this is going to be possible. And we still have a lot to demonstrate before this becomes an option, but I think it's certainly worth exploring. There's 3 devices now. All of them deserve to be explored.
I think it's amazing that actually many cardiologists thought that interventional and prosthetic valves were dead in the water. And actually, over the last 4 or 5 years, our understanding has changed. And I think it's a bright future now for the mitral valve in dogs. And there are many dogs who stand to benefit. One of the big limitations, I guess, is cost. And that's definitely going to inhibit access for lots of people, I think.
Cost of the edge-to-edge device, cost of...
I think cost of anything at the moment is inhibiting access for many people. But I do think, you talked about them being complementary for one another. And actually part of that for me is different levels of price, in that some people will have a more restricted budget. Maybe their insurance company covers a certain amount of money, but they're not going to go the whole $35,000 for repair. So therefore, a trans-catheter procedure might be the best hope for that patient, given that limitation.
For sure, access to surgical repair and cost of surgical repair have been barriers that have pushed the development of TEER. Surgery has been around long enough now to where we'd like to be optimistic that there'll be more centers like the Jasmine Center in Japan, which is now over 1,000 cases and has pretty good results. We'd like that to be more available. I think the hope for TEER, it's not as expensive, although it's not inexpensive for the device. The hope for TEER is that there can be more centers around the world. I think people will have to understand, cardiologists and families as well, that there's going to be a learning curve. There has been a learning curve. And whenever a new center opens up and completely commits to this procedure, there's going to be a learning curve. And that's extremely painful for everybody involved. But if we can get to the point where we understand who should get the procedure and have consistent results, they'll never be perfect. But I think if we look at the survival curves right now, it's not a direct comparison to medical therapy alone, but I think if we look at the numbers, most cardiologists would say, I don't expect a dog with these kind of numbers to be alive 2 years later. So I think the future is very promising. I would love to stick around and see what happens. Thank you for inviting me. I think this was an amazing opportunity for me to share some thoughts. So I appreciate it.
I think people are going to be super interested to hear everything you've talked about.
Kieran and I talked many times about that talk you gave at ECVM in Maastricht, I think, because it's incredibly inspiring, really, that you talk from bench research to high-end clinical research. So honestly, thank you very much for that. You are truly an inspiration for us. Because, many people do bench research, many people do clinical research, and you cover these huge spectrums. So that's absolutely fantastic.
Yeah, I completely agree.
Thank you for that.
It actually leads me to a question that I've had in the back of my mind as we've been talking. So you've looked at all the work on disease in the dish models, you've looked at serotonin, and there's hope there for medical therapy to prevent dogs ever needing surgery. Do you feel conflicted about that as a surgeon?
Not at all. I feel whatever we can do. I mean, when you look at how much these dogs mean to these families,
right?
Anything we could do to reduce the burden of this disease through medical therapy, interventional, surgical treatments, it's all good. It's all the right thing to do. I would like to see the bench work become something clinical. But I think it's all good. I am not conflicted at all.
Good. Fantastic. Chris, it's been an absolute honor. Thank you so much for joining us. And thanks to everybody for listening.
Thank you.
You bet. Thank you very much for having me.
And good luck with your procedure.
Thank you.
Bye-bye.
Take care. Bye-bye.
Bye.
You have been listening to the Animal Heartbeat. Thanks very much for our listeners.
Keep in touch by finding us on social media or sending us an email on animalheartbeat@gmail.com. Please remember to like, follow, and share to help us find new listeners. And make sure to check out our previous episodes wherever you get your podcasts from or on our YouTube channel.